Good evening. Thank you for joining us for tonight's educational webinar on managing ankle sprains. Tonight's speaker is Dr. Jeff Gittins, OrthoNeuro orthopedic surgeon and foot and ankle specialist. Dr. Gittins is a board-certified orthopedic surgeon specializing in sports medicine and adult foot and ankle reconstruction. Dr. Gittins served as team physician for many high schools and university. He is currently the team physician at Johnstown High School. He has published articles in clinical orthopedics and related research and has written chapters in textbooks for shoulder and foot and ankle arthroscopy. He is an associate master instructor for foot and ankle arthroscopy for the Arthroscopy Association of North America. Dr. Gittins will answer questions following his presentation. Please type your questions into the Q&A box at the bottom of your screen. Dr. Gittins?
Thank you. Thanks, Heather. Good evening, everybody. Thanks for joining us. Tonight, we're going to talk about the good, the bad, the ugly of ankle sprains. Ankle sprains affect all of us, whether or not we're doing professional sports versus collegiate sports versus Olympic athletes. As we talk about ankle sprains, it's very important to understand the prevalence of ankle sprains. We're going to speak tonight about the anatomy and discuss that a little bit, talk about the examination that we might do for someone who has an ankle sprain. We'll go into briefing the classification systems of what it means to have an ankle sprain that you might hear when you talk to different types of physicians. We'll discuss the treatment plan for ankle sprains, talking about conservative care versus surgical rehabilitation as well. When can an athlete return to sport? That's something we'll touch upon as well. Finally, we're going to talk about complications, any type of new controversies that are out there discussing ankle sprains, including high ankle sprains. There's more than 11 million visits to the physician's offices in 2003 because of foot, toe, and ankle problems, and more than 2 million visits for ankle sprains. To this day, the number one reason someone goes to the emergency room or urgent care is because of an ankle sprain. So they're very prevalent. Walking puts up to 1.5 times your body weight on your foot. The ankle itself absorbs anywhere between 5 to 7 times your body weight of stress going across your ankle joint. As shock absorbers, your feet cushion up to 1 million pounds of pressure during 1 hour of strenuous exercise. What about the cost? We never really think about the cost, but typically the cost of an ankle sprain can reach up to $1,000 typically. Some of that involves evaluation, some of it also involves x-rays. There's a paper out of Ottawa, Canada that discussed, well, who needs x-rays when they have an ankle sprain? It's designed to help control the cost. And that's basically if anybody has pain along the bone or certain areas of the bone, then an x-ray is warranted. If there's just pain to the ligament, typically they want to stay away from doing x-rays. However, this was looking at ankles for risk for fractures. When we evaluate someone for an ankle sprain, what we're looking for is not necessarily a fracture, although that is an important thing to rule out. We're also looking for secondary injuries, including osteochondral lesions or subtle fractures or loose bodies or instability of the joint line. Lateral ankle sprains account for 85% of all ankle sprains. 25,000 ankle sprains occur in the United States every day. Ankle sprains are often undertreated, resulting in chronic pain, muscular weakness, and instability, not to mention loss of work and time away from family or doing activities of leisure. There's 1 in 10,000 persons per day is how often it's affected. It's associated with many types of sports, including football, volleyball, and basketball. Wrestlers can be affected. They're usually affected in the opposite way that most people injure their ankle because of their stance when they're wrestling. It's typically going to be an inversion injury of a supinated foot. It's plantar flexed and accounts for 85% of the injuries. The number one ligament that's injured is the anterior talofibular ligament. The one that's the strongest is the calcaneal fibular ligament. And these are the two ligaments that sit on the outside part of the ankle. The deltoid ligament is the ligament that sits on the inside part of the ankle. Brief anatomy, this is a cadaver dissection, but number 1 is the fibular bone. Number 2 is the tibia bone. Number 3 would be the talus. Number 5 would be the anterior talofibular ligament. Number 6 would be the calcaneal fibular ligament. And number 7 is the deltoid ligament. This is another cadaver specimen showing you a different range of motions of the ankle and how it puts a different stress upon the ligament. In 90 degrees or neutral position, the ligaments are tight in the anterior talar filament. In dorsiflexion, they become somewhat lax, but the calcaneal ligaments go into tension. When we examine somebody, we examine them for different things, including where their pain is. Do they have pain when you press on their ligaments? What's their range of motion like? How much swelling do they have? Do they have bruising? There's certain tests we do, and we've listed several of these tests right here. An anterior drawer sign is basically a test where we grab the back of the heel and we try to shuck the ankle forward, trying to tension the ankle ligaments in a range of motion. Inversion stress test is depicted here in the cartoon, where we roll the ankle in, trying to stress the ligaments as well. And typically we're looking for a painful stimulus. If someone doesn't like that, or you feel there's laxity or increased range of motion, that can be indicative of an acute ankle sprain, but it could also be indicative of ankle instability, meaning long-term ankle laxity. When it comes to anatomic classification, there's two different types of ways of classifying an ankle sprain. The anatomic classification is where you describe the ligament itself, whether it be mild swelling with minimal pain in a type 1. In grade 2, there's moderate swelling and painful areas of palpation, but there's a complete tear of the anterior talar filament, and there's only a partial tear of the calcaneal fibular ligament. And then finally, in a grade 3, there's gross swelling going around the ankle with loss of motion. It's very painful. There's most likely a tear of both lateral ligaments, but also the deltoid ligament. So basically, this is counting how many ligaments you hurt to determine the anatomic classification. With the AMA standard classification, here they're describing the exact injury to the specific ligament. At grade 1, it is a attenuation of the ligament or a stretch. At grade 2 is a partial tear of the ligament. And then grade 3 is a complete tear of the ligament. So it's important to understand what type of classification someone's using when they're trying to describe that to another physician. Typically, we do x-rays. We're looking for whether it be fractures, whether it be osteochondral lesions, or gross instability. Here, we're doing stress x-rays on an individual showing the gapping of the ankle joint, showing and depicting gross instability ankle joint. MRI is the next test that we normally would do if we're concerned about the ankle ligaments themselves. It's not the first test that we do. X-rays usually are. It's usually a test that we'll order if we're concerned about gross instability or someone hasn't progressed as well with conservative care. But in an MRI scan, we're looking for the assessment of the ligament damage. Also, we can look for any type of damage to the bone called an osteochondral lesion or an injury pattern to the talus bone. There can be bone bruising to determine the extent of the injury. The bone can swell, and that will show up on the MRI scan. And that can be a cause of someone having long-term pain as well as swelling. The MRI aids in assessing how much kinetic energy was absorbed by the ankle during the injury mechanism, which can be very significant for individuals. How do you treat ankle sprains? Typically, you're trying to control the pain initially, whether it be resting, immobilization, icing, elevating, non-steroidal anti-inflammatory medicines, as well as compression. These are very common. But once the pain is controlled, then we begin the rehabilitation process. So initially, we want to be able to control pain, whether that means going to a compression dressing with a boot or a compression dressing with an ankle brace. Some people have enough pain where they're in a boot and they need crutches because it just hurts too much to walk on it. Our main goal is to control pain initially. When we begin rehabilitation, our goal then is to control pain without the risk of causing more pain. We then work on proprioception. That's the ability of the ligaments to give us feedback as our foot touches the ground to keep us balanced. We work on peroneal strengthening. Those are the two tendons on the outside part of the ankle. We're working on trying to get that strength back. We work on getting the motion back so they're not stiff, so we can have full motion to the joint. We still want to be able to control swelling. We also want to make sure we're not getting more pain as we're going through the rehabilitation process. When can an athlete return to sport? Typically, you want to make sure that they don't have any pain. They have near full range of motion. Their strength is returning. Their proprioception is returning, so their ankle can give them feedback as they're participating in the sport. They can complete simulated skills of the sport. A lot of times we can get them back wearing a simple ankle brace, but the goal is to get the patient to where they don't feel they need the brace. The goal is to get them back playing a sport. They may not be 100%, but at least they feel comfortable getting back without the risk of re-injuring their ankle as they continue with the rehabilitation process, however. Factors that can slow a patient's return to sport, that includes non-compliance, just not following the doctor's directions, whether not doing the correct activities or doing the wrong activities or just overdoing the activities. There's a whole bunch of continuum that patients can be. Again, swelling, stiffness can prevent somebody from getting that full range of motion back. That means their foot and ankle is not going to be as in tip-top shape when they try to return to sport, and it can be very frustrating for a patient. That slows the return. But persistent pain is one of the biggest things we see. With chronic instability, such that people have had problems with their ankle chronically, they may have had an injury pattern when they were 18, when they were playing a sport in high school. Now they're 40 and they're still having problems. Well, they may have injured their ankle recently. So that's an acute on chronic injury pattern. So the concern then is, did they injure their ankle ligament so bad? Now they have a considerable amount of weakness and they show signs of instability. They can't control their ankle anymore. You typically want to do conservative care for them at first as well, trying to brace them, trying to do some physical therapy for them to rehabilitate them. But sometimes they fail that as well. And that's when you have to consider doing surgery for them. When it comes to ankle reconstruction, there are several aspects of reconstructing someone's ankle that's very, very important. Ankle arthroscopy is one of those things. That's where you put a camera inside someone's ankle joint to visualize the ankle joint so you can take care of any type of pathology that may exist inside of the ankle joint. That includes loose bodies or scar tissue, impingement lesions, osteochondral lesions. That's where someone may have twisted their ankle so hard they knocked off cartilage inside the ankle joint. Now the bone's exposed. It's very, very uncomfortable for them to participate in that lesion. That may not show up in X-rays. It may show up only on an MRI scan. I've had other people who doesn't show up at all on an MRI scan, but you see it arthroscopically, and then it's important to take care of it then. Modified Brosnan procedure is a first-line procedure where you reconstruct the ligaments and you repair them and tighten them down. Typically, what I do in a modified Brosnan procedure, what I'm trying to do is create layers to the ligament as well as the extensor retinaculum to reinforce the repair of the ligaments, but tighten them down to give them more stability. There's an anatomical reconstruction of the ligaments with an autologous tendon transfer, and that's what this little cartoon is trying to depict for you as well. Sometimes the ligaments are so stretched out or they're patched, they're not very good ligaments, and so you have to reinforce them with a tendon. This is kind of an old school way of doing things. It's still done these days. Nowadays, we have a new armament where we actually would do a bridge, which is a suture bridge to reinforce the primary repair of the ligaments versus going straight to a tendon transfer. This is a cartoon depicting the modified Brosnan procedure. The yellow dotted line depicts the incision. I actually like to do this a little bit different. I make my incision in line with the fit of the bone, just in case we have to go back and revise that at one point in time. That suture line should not cross over any type of specific lines and cause more problems down the line. Where you repair the ligaments primarily, but you also reinforce by bringing the retinaculum up as depicted in cartoon D. There are several injuries that can be associated with lateral ligament ankle sprains, including partial or complete tears of the tendons on the outside part of the ankle. They're called the peroneal longus and peroneal brevis tendons. Sometimes those can be injured, whether it be acutely, which is rare, but also long-term when they have chronic instability. They're recruiting the tendons over time, and the tendons will wear out. They're not designed to give ankle stability over time. People can also have chondral fractures of the talus, where I mentioned before, an osteochondral lesion. They can have traumatic injury to the ankle itself. Medial ligaments injuries can be injured, specifically the deltoid ligament. We usually pay attention more towards the lateral ligaments, but the deltoid ligament on the inside part of the ankle can be injured as well, according to how severe the ankle sprain was. What about the newest thing? One of the newest things out right now is doing arthroscopic reconstruction. This is one of the newer things that we're doing more and more research on. Basically, it's still an arthroscopic procedure, but what we do is we pass anchors arthroscopically into the fibular bone, and then we pass sutures arthroscopically through the ligament as well as to the extensor retinaculum. Then what we do is we make a small incision on the outside part through the skin. We pull the sutures out and we reduce the ankle back into neutral position, and we tie down those ligaments. That reinforces the ligaments, but also the retinaculum. And it's found in favor in many places these days. The internal bridge, I call this the internal bridge of Manda, but this is a bridge where you not only repair the ligament primarily, but you also put down a large suture bridge from the ankle bone called the talus into the fibular bone that reinforces the ligament. Sometimes the ligaments are a little bit weaker, and as you repair them, it's nice to have a large suture in there to give you some support until the ligaments have a chance to heal. The important thing about this is that you can't just put a suture bridge in there and expect it to reconstruct the ligaments. You have to be able to reconstruct the ligaments. The bridge will be there, help take some stress off the ligaments until they can have a little more time to reconstitute, but you have to do both at the same time. Syndesmotic injuries are another form of an ankle sprain. It can occur with displaced or non-displaced avulsion fracture of the fifth metatarsal. You can have fracture of the lateral process of the talus. It can be post-sprain neuritis of the sural nerve. These are all associated injuries that happen with ankle sprains. So a lot of times an ankle sprain is not just a simple ankle sprain. There can be several other things that can complicate this type of injury. When we talk about syndesmosis injuries, it's a sprain of the ligamentous structures about the ankle, which is just above the ankle joint proper, called the syndesmosis. It connects the ankle bone, specifically the fibular bone, to the tibia, just above the ankle joint, and it's called the syndesmosis. Some people will call this the high ankle sprain because it sits just above the ankle. The syndesmosis sprain can include incomplete disruption as well as in fractures and simple sprains and stretching of the ligament. It can be complex. Sprains of the syndesmosis have been estimated to occur in as many as 18% of all ankle sprains. Minnesota Vikings did a study over a 6-year period, and 18 of the 98 ankle sprains reported were classified as syndesmotic sprains, otherwise known as a high ankle sprain. These are subtle, so you have to be really cognizant of them and be suspicious that that may be going on, because in the long term, if a syndesmosis or a high ankle sprain is missed, it can lead to arthritis between the two bones in that joint space. The syndesmosis includes the anterior inferior tib-fib ligament. There's also the posterior inferior tib-fib ligament and the interosseous ligament. The anterior inferior tib-fib ligament is most commonly injured. With a Mason-New fracture, this is a specific fracture that occurs with a syndesmotic disruption. So someone sprains their ankle so bad, the energy travels up the outside part of the ankle through the syndesmosis, through the interosseous ligament. It tears the syndesmosis ligament, but also leads to a fracture more proximally towards someone's knee of the fibular bone. And this is called a Mason-New fracture. With a syndesmotic injury, it's typically with external rotation. There's hyperdorsiflexion. There's a medial directed force onto the lateral ankle when someone falls onto another's ankle, such as in rodeo injuries, when the rodeo rider or cowboy gets stepped on. There are well-localized anterior lateral ankle pain just above the joint line. They can have minimal swelling at times, but otherwise they can have swelling similar to an ankle sprain. There's very little bruising that can be delayed at times. And again, you want to examine proximally for a possible fracture, what we call a Mason-New injury. Different types of examinations you can do to determine whether someone has a high ankle sprain or a syndesmotic disruption includes a squeeze test. You can do a shuck test, otherwise known as a cotton test. External rotation test is the most positive, and that's where you rotate the ankle out and you palpate at the same time in this area, seeing if they have pain when you rotate them out. Here's the cartoon depicting the external rotation test. And once again, they would have pain when doing this. 10 to 50% of syndesmotic injuries have a bony avulsion. They can have a weight bearing, or x-rays can be able to delineate this type of injury. And you have to be very suspicious of it because sometimes these fractures can hide behind the bones themselves. Sometimes we can do stress radiographs to determine whether or not the syndesmosis wants to open up, and that's usually combined with a ligamentous damage to the ankle proper. How do you fix syndesmotic injuries? The old school way is putting screws across the two bones at the ankle joint. And the question was, well, then when would you remove the screws? And some people would never remove the screws. They would let the screws go on to break sometimes. The screws sometimes became painful for the individuals. Well, now we have what's called suture buttons, and the suture buttons are designed to hold the two bones together through a drill hole placed across both bones, but it's made of suture and it's tethered by two buttons on either side of the bone. It squeezes the joint together, but it's made of suture. And so the suture has a little bit of give to it, but we don't have the downside of having to go back to remove a broken screw. If the suture wants to go ahead and break, it's fine. It won't cause the patient a lot of problems. It's very rare that we ever have to take out a syndesmotic fixation using suture buttons these days. So therefore, we're able to avoid screw complications. There's no need to remove it. It's difficult to over tighten with the suture button. However, it can be done. You just have to be aware of that. It can be done arthroscopically as well, and there's no large suture knots. Complications of ankle sprains include abnormal proprioceptions. The ligaments just never bounce back to where they once were. There may be an imbalance in muscle weakness that causes a re-injury. And so when somebody has re-injuries, it can lead to gross instability where the ankle just remains very, very weak. Sometimes if someone doesn't follow the proper protocol to return after their activity, they can cause chronic injuries to the ligaments themselves. And that can lead to instability, and they have increasing pain as well. With impingement syndrome, it's 20 to 40% of cases following an ankle sprain. The pain is reported several weeks to months after inversion spraining. There's anterolateral impingement of the ankle, where basically the patient develops scar tissue within the ankle joint. That scar tissue is bigger and thicker in the joint space, and now it impinges or gets stuck in the ankle joint, causing pain and discomfort, usually with range of motion. There's pain along the inferior fibular bone and the anterolateral talus and the lateral gutter. And once again, it's usually a wad of scar tissue which is causing the pain. Impingement syndrome can be treated by ankle arthroscopy, and ankle arthrotomy is no longer needed. So what's the standard of care when someone has an injury pattern? Elasticated pre-shaped compression stockings was routinely used in treatment of 55% of the patients, while mobilization using cast or a brace is used only in 5%. The goal is to control pain. So the question is, how long do you immobilize somebody? Because as long as you keep the joint immobilized, it will get weaker. So the goal is control someone's pain, but get the range of motion back as soon as you can, with being protective of the ankle joint to avoid any type of further injury. There's no major rule in place for surgical repair of acute ligament ruptures, meaning if somebody comes in with an ankle sprain, typically you do not want to rush them off into surgery. Typically, treat them conservatively and try to rehabilitate them. There are those few who go through rehabilitation who do not succeed very well with therapy and then may require surgical reconstruction, but most patients will do quite well with conservative care. When it comes to immobilization, some people feel like it should never be used. I use immobilization in a cast boot, but I also try to get their pain under control first and then try to rehabilitate them away from their boot once their pain is more controlled into a brace, and then do an aggressive physical therapy program to get someone back to enjoying their sports or their activities of living. What about prevention? How do we prevent ankle sprains from occurring? It's an important question. If the first time ligament injury can be prevented using proprioceptive training, it's a goal. It's a matter of educating that patient the proper way of stopping or starting or pushing off. We've gone on to certain sports where we're using breakaway bases now for baseball and softball. It's where we have commonly had ankle injuries. We also use safety bases, which are the orange bases you may see on the ball fields. And those are designed to keep the first baseman and the runner away from stepping on each other to avoid ankle injuries. But these are things that we're trying to do to keep people from injuring their ankles. Proprioceptive training and external ankle support are available to help prevent further ankle sprains. Again, I think some athletes enjoy using an ankle sprain, especially if they're playing volleyball or basketball where they're coming down on other people's feet or ankles. It gives them some support, but it doesn't take away the fact that you still have to get your ankles stronger to be able to play those sports. Bracing and taping can be a benefit. However, taping usually lasts about 20 minutes and 50% of the strength is now gone. There is a proprioceptive benefit to some taping, but there's a cost that goes along with taping, which needs to be addressed. Thank you.
Great. We have some questions today, Dr. Gittins. The first question is, if you need to wear a boot for pain control, how long do you typically need to wear it?
Wearing a boot for pain control depends on the athlete as well as how much swelling they have. But if it's just a simple ankle sprain, they have pain where it makes it very difficult for them to weight bear, then you're usually in the boot for at least 2 weeks. At that point in time, then we reassess them and try and see when we can get them away from their boot back into an ankle brace. Some people don't like a boot. It's hot, it's heavy, it mobilizes them, but that's the point. What I've found, if you try to put somebody in an ankle brace when they probably should be in a boot, it just extends their recovery time. So our goal is to control their pain first and then try to rehabilitate them aggressively once their pain is more controlled.
Great. Do all ankle sprains become chronic?
No. Some people have just simple ankle sprains, which can be treated conservatively and they'll never have another ankle problem whatsoever. It's those individuals who've had one bad ankle sprain but may have not been treated very well, or they have multiple ankle sprains that still aren't treated very well. that can lead to some problems, including instability. But what I didn't mention as well is that if you have chronic instability in your ankle joint, you can get arthritis. And I've seen a lot of patients who come in with injury patterns when they were in high school. Now they're 40 or 50 and they had advanced arthritis to their ankle joint because they never took care of their ankles.
So when should I see a doctor when I sprain my ankle? Every time, immediately after, or should I race first and then see how it feels?
Yeah, these are all good questions. It's always a challenge. When do I have to go see a doctor? Take time out of my schedule. It's one of the things that if you have enough pain, if you're limping, it should be evaluated. It's not that you most often can't recover from ankle sprain and do quite well. It's a concern if you have enough swelling and you're limping because of pain, you may have damaged something else inside the ankle joint. It needs to be evaluated. Besides that, if it's all negative, then we treat it as a simple ankle sprain, if you will, control pain, rehabilitate aggressively, and get you back to your sport.
How successful is ankle surgery for stopping pain and instability?
Very successful. Surgery is indicated when you fail conservative care. That should be stressed. If someone comes with an ankle sprain, it doesn't mean you're going to get surgery right away. By far, that's not what's going to happen. You'll be treated conservatively. But it can be very frustrating when someone deals with an ankle problem chronically, or their ankle just never responds with physical therapy, or they have chronic pain that's just not getting better with physical therapy or other things, including injections in the office. That is when surgery is indicated. And usually before we do surgery, we'll do an MRI scan to figure out what is the status of the ligaments. Are there any other pathologies that need to be addressed at the time of surgery? But when you fail conservative care, we have a good game plan going forward to take care of the ankle from a surgical standpoint. Surgery is a great tool to be utilized at that point.
Do you ever need to fuse someone's ankle due to an ankle sprain?
The answer to that question is no, with a caveat or an asterisk, if you will. If someone has advanced arthritis and they're spraining their ankle may have enough arthritis, then it may have to be fused. Nowadays, when it comes to treating ankle arthritis, we simply don't just fuse the ankle. We have ankle replacements, which are available to us as well. One of the benefits of an ankle replacement is you maintain the motion to the joint, but you relieve the patient of the pain.
So what is a high ankle sprain, and is a high ankle sprain worse than a lateral sprain?
Yeah, a high ankle sprain is typically going to be a little bit worse than a regular ankle sprain or a lateral ankle sprain. The reason being is usually because more energy goes across the ankle for that type of injury to occur. It can still be rehabilitated, but the concern is whether or not someone will do very well with that physical therapy program with a high ankle sprain. It gets missed a lot of times, and that's why it takes such a long time to get rehabilitated for it. But when it gets missed, sometimes those do require surgery.
How long does it take to heal a high ankle sprain?
Typically, high ankle sprains are going to take just a little bit longer than an ankle sprain normally does. Ankle sprains get better within 4 to 6 weeks. High ankle sprain treated conservatively can heal in between 6 to 8 weeks typically, as long as it's swelling, the pain is controlled.
What is the treatment if you have a fracture with your ankle sprain?
It depends on what type of fracture, but when you sprain your ankle, you typically invert your foot and you rotate out of your ankle. That tears the ligaments in a consistent fashion, going from around the outside part of your ankle. The end extent of that is you tear all those ligaments. As your motion keeps going around, then you'll break your ankle. Some people have an avulsion fracture. When they sprain their ankle, they tear the ligament so hard it pulls a piece of bone up with it. That's an avulsion fracture. Typically, then that does not need surgery. That needs to be rehabilitated. That's taken as if it's a really bad ankle sprain. If somebody happens to break their ankle where it needs to have surgery, the ankle sprain itself will take care of itself once the bone is fixed and it's put through its healing process.
Will I always have a bigger ankle on the sprain side?
Not necessarily. Usually someone has a bigger ankle because their ankle has led to chronic swelling or multiple ankle injuries. That's why it's always remained somewhat larger than the other one.
How long is the rehab after a significant sprain?
Typically about a month. And why I say a month is once we have your pain controlled and we start to rehabilitate you, we should be able to start getting you back to playing sport. But we can't have the episodes where we keep re-injuring our ankle because that will set you back.
So we have another one on when should you go see the doctor?
It's the same answer for the most part. It's If it's a simple ankle sprain and you're walking around and it doesn't give you a simple amount of pain, but it's tender when you touch it, then you're probably okay. If it should give you long-term pain, meaning it doesn't get better within a couple of weeks, you probably should go see the doctor. If you have a significant primary injury where your ankle swells up, it's bruised, it's difficult to walk on, you should go see a doctor at that point in time, because then we're looking for secondary injury patterns.
And do you do ankle replacements?
I do ankle replacements. They're kind of new. They've been out since, they've been released here in the United States since early 2000. They've actually been done in the United States since mid 90s, I guess. They're picking up more pace nowadays because their technology is better. Yes, I do ankle replacements.
And that was the last question that we have. Are there any additional questions? Well, thank you very much, Dr. Gittins, and thank you to our tonight's participants. Our next webinar will be held on Tuesday, August 1st. Dr. Martin Taylor will be speaking on therapeutic uses for Botox. Enjoy the rest of your evening and good night.
Good night, everybody. Thank you.